Good morning, everyone. So first of all, I would like to thank you, the ISN SICON Organizing Committee, for giving me this opportunity and to bring forward the most, I think, the a highly underdiagnosed and under-recognized glomerular disease into public for discussion. So it's very high time that we address this public health issue by creating awareness among ourselves and among the public. So if we classify the toxins, these are the classification that affects the different types of toxins that affect the kidney. So I will be more concentrating on the environmental toxins and the heavy metals. So definitely there is a rising incidence and a diverse presentation in glomerular diseases, and which makes us think beyond the conventional factors. The global rise in kidney disease associated with environmental toxins is definitely a growing public health concern. The air we breathe, the water we drink, the food we consume, and even the skincare products all can be potential contributors to the glomerular disease. As we all know, because of the filtration, the kidney is susceptible to the increased effect of these toxins, and even they get stored in the kidney, like cadmium, mercury, the heavy metals get stored in the kidney for a long time. So it is a pressing need of our time to pinpoint and thoroughly investigate the environmental risk factors and their impact on kidney disease. So before I go into the topic proper, I would like to revolve my discussion around our case series, our experience at our hospital. So we have been, when we started looking at the NEL1 positive, NEL1 staining for our membranous nephropathy, we started to see increasing number of NEL1 positive cases. So the cohort, like all were young people with median age of 30 years, with equal representation of both males and females. A very important point to note is that all had subtle symptoms. Though their proteinuria was in the range of 25-24 grams per day with severe hypoalbuminemia, they had very subtle symptoms. Mostly they went with fatigue, proteinuria, they go to the lab, check the protein, check the routine test done, and they get self-referred to a center. Baffled, NEL1 positive, we evaluated the patients, we sent for the viral markers, we worked up for malignancy, we worked up for autoimmune disease, we didn't get any history of traditional Indian medicines. So we are also very confused with these cases. And just finally, we could pinpoint in one particular patient the use of fairness cream. Over-the-counter cream was very widely available in our area, spread by word of mouth and through the social media challenges where they run the campaign of 7-day challenge or get the money back. And the result was very evident. As we know, these creams may contain high level of mercury, which inhibit the tyrosinase enzyme and inhibits the melanin production. It causes desquamation of stratum corneum or layer of the skin, and which produce very thin skin, and the result is just amazing. And the patients themselves say they're very reluctant to stop usage of this cream because of the result. So we had in mind the cream may be the causative factor of the disease. So we have a group with our pathologist. In that we just suggested the cream may be the cause. It's the first message that came to us. So this is a case in Austria where the sewage treatment plant got alarmed because of high level of mercury, the sludge. And they could trace it actually. They had very good system. They could trace it to a household where a woman had recently come back from India carrying the face cream and powders. And when they estimated the amount of mercury in that, they found it would amount to about 4 kilograms of mercury. Just imagine the amount of mercury that is contained in these creams and powders. So keeping that in mind, we did a literature search in India. So mostly the data is from Tamil Nadu. This is a case series from Apollo Chennai where they had 5 patients with traditional Indian medicines, all nephrotic syndrome, membranous nephropathy. And the good thing is that withdrawal of traditional medicine had remission of nephrotic syndrome. And 2 patients had received chelation therapy in the form of DMPS. This is another case series by Dr. Priyamada and team from JIPMER, published in Kidney International 2020. 8 patients with consumption of indigenous medicines with high level of serum mercury or membranous nephropathy. Here also they had remission after withdrawal of indigenous medicine, and 2 patients in this cohort had received corticosteroid. They also had recent publication 2023 where they compared patients with steroids and on conventional treatment, and they found that patients with very high level, very high proteinuria and very high proteinuria had attained remission earlier if they were treated with steroids. So this is one of the classical paper, I would say, which actually linked the target antigen in mercury-induced membranous nephropathy to NEL1. So this is by Dr. Anil Abraham and team, where they had a cohort of around 146 patients over a span of 5 months, all membranous nephropathy. And they had a staggering number of 66 patients. 35% of patients had history of traditional medicine use. And among them, 88% were positive for NEL1. So coming on to that subset of 66 patients with membranous nephropathy, all of them had indigenous medicine consumption in the form of Swasakalpa, Rasakanti. 44 were on regular follow-up and 11 received some form of immunosuppression in the form of steroids, rituximab and modified Ponticelli. One of the patients who received modified Ponticelli actually died. 21 patients had complete remission, 13 partial remission, 11 persistent disease. And it was concluded that there was no correlation between immunosuppressive therapy and remission. This is another important paper. It got accepted in kidney medicine yesterday. I really like to congratulate Dr. Gopalakrishnan sir and his team for this paper and for providing me with this data. They had a cohort of 19 patients, and the patients were majority of membranous nephropathy, minimal change disease, and 17 patients they had tested with high blood levels of mercury, and they had majority of the patients on conservative management, and majority of them recovered. 17 patients had recovered with conservative management. This is coming to the international data what I have collected. This is a publication from BMC Nephrology. The membranous nephropathy due to mercury containing skin creams due to the occupational exposure and due to the mercury containing fumes. And majority cases were membranous nephropathy, and second most common was MCD. This was published in Italian Society of Nephrology with cases of membranous nephropathy secondary to use of skin whitening cream containing mercury. Here also the majority of the case was membranous nephropathy and minimal change disease. Here, as you notice, one important point to highlight was the positivity of ANA, autoantibodies, could be detected in these patients, maybe because of the autoimmunity induced by mercury. So here also the patients received immunosuppressants, majority of the patients received some form of immunosuppressants, and all of them were in remission, and there was no relapse. So coming back to our cases. So we collected all the face creams that this patient used, sent them for heavy metal estimation, and look at the mercury level in these creams. It was 10,000 times the permitted levels. The mercury levels were 10,000 times. They even contained metals like cadmium, strontium, and lead. Though the level of cadmium, strontium, and lead were below the permissible limit, the combination of these metals may induce toxicity, because even if the levels are below the permitted level, because of saturation, because of the involvement in the kinetics of the metal toxicity, even the level is normal, it can induce toxicity. So I would like to highlight one paper published from PGI where they looked into a strontium-induced membranous nephropathy in patients using treatment for acne. So this was the result of the cream analysis. So coming back, so we sent heavy metals in our patients. So 8 out of 11 patients had high level of mercury in blood or urine. We went back and took all the membranous nephropathy patients from our hospital. We stained them for NEL1, and we found that 68% were NEL1 positive, very high number. 68% were NEL1 positive in our cohort. And one good thing was that all patients achieved partial or complete remission with cessation of usage of cream and RAS inhibition. This is under review for publication Kidney International. So coming to the data, so we have a data from north and south. So clearly you can see the incidence of NEL1 membranous nephropathy is more than twice. If you compare the data from this unpublished data from LALPATH and RENOPATH, the NEL1 positive cases is more than double in this area, our South Indian area. This is mainly because of the belt of use of Siddha medicines. You know, the South Indian state are very famous for use of traditional medicines, and this is imbibed in their culture. So as the map clearly shows, the area where the Siddha medicines is more commonly in use. So coming to pathophysiology of mercury poisoning, the key determinant is the chemical form, whether it is vapor form, inorganic form, organic form. The inorganic form is that that affected the kidney the most, and the route of exposure and the dose. The absorption of inorganic mercury can occur by the transepidermal and transappendageal route. It induces autoimmunity. It causes T cell mediated B cell proliferation and T helper 2 cell response. And there is a high affinity for mercury to sulfonyl group of the glomerular membrane, which interfere with the cellular process and causes interfere with the podocyte GBM crosstalk. It can cause conformational changes in laminin, fibrillarin, or VCM, causing increased interaction of immune complex with membrane components. And why in L1? Why in L1 is phosphine membranous nephropathy? Maybe it's postulate, maybe because of the injury to the proximal tubular cell, where the L1 is highly exposed, mercury causing ATN, injury to proximal tubular cells, exposes in L1, and it is causing some form of autoimmunity. So the immune deposits are predominantly IgG1 subtype. The mercury-induced MN has also been characterized by C1q deposition and mesangial immune deposition. The most commonly encountered glomerular disease is MN, and second most common is MCD with a rate of 25 to 60%. And one important takeaway point is that long-term exposure to mercury may result in a persistent immune state even after clearance of mercury. Many of the patients still complain after 1 year, 1.5 years after the exposure. They still have some form of somatic complaints or vague complaints which cannot be explained by anything. And one of the reasons may be because of the persistent immune activation in this group of patients. Is it dose alone that is causing the issue? No. There is definitely a role of genetic polymorphism in L1 as evident by other diseases other than not in kidney disease, but other diseases when L1 is implicated. There's definitely genome-wide analysis show definitely there is an L1 polymorphism, as in the case of pediatric disease also. Treatment, no consensus, as I already discussed. There is lack of treatment consensus, no universally accepted or agreed upon treatment. Chelation therapy may be considered when the mercury level is very high, more than 100, very difficult to procure, not a standard procedure. Conservative management is the preferred initial approach. The half-life of mercury is around 50 days. We may have to wait for more duration, maybe in our case series we found the median duration to be about 5 months. Utilize RAS blockage, statins and SGLT inhibitor. Steroid therapy may be reserved in cases where conservative measures fall and used to address the autoimmunity induced by mercury. This is another source of occupational exposure to membranous nephropathy published in CJASN in French workers, where they found that asbestos and organic solvent can cause PLR2 epitope spreading with increased incidence of membranous nephropathy. PLR2 membranous nephropathy actually. So next, I will like to discuss about the air pollution and the glomerular disease. Very gray area. We don't have much data from India. Most of the data are coming from China, where they found increasing incidence of membranous nephropathy, PLA2R positive membranous nephropathy in young age population is almost from 17% to 29% over a span of 7 years. So what they have after abolishing all the confounding factors, they could attribute it to probable the air pollution as a cause of the glomerular disease. So our Central Pollution Control Bureau's average permissible limit of particulate matter 2.5 ton and nitrogen dioxide are 40, 60 and 40 respectively, while the WHO recommended standards are 5, 15 and 10. The actual level is much more above the permissible limit of the CPCB actually in our metros. So the relationship is non-linear. Each 10 microgram per meter cube increased from 70 microgram result in 14% higher odds of incidence of PMN. The prevalence of membranous nephropathy in China in the cities have actually increased from 12 to 24% during the decade, where the exposure to PM2.5 has increased from 6 microgram to 114 microgram. So how does it causes? How does air pollution is linked with glomerular disease? There is definitely increase in TNF alpha, interleukin 6, plasminogen activator inhibitor, and the link to genetic polymorphism. This is a very important factor. Genetic polymorphism is the one that is mainly predisposing this group of patients. The recruitment of alveolar macrophages or neutrophils, both of which express the PLA2R proteins and result in immune response which target the PLA2R in the glomerulus. PM2.5 might bind transcript factors in podocyte and increase the PLA2R antigen expression and consequently initiate antibody production. So this is a nutshell, the pathogenesis of pollution kidney disease. I'll skip the slide, already discussed it. This is we know the water bodies are immensely polluted because of the industries, mining, agriculture, and urban waste. The metal levels in water bodies are very high, and definitely it get assimilated in the fish and the crops that we consume. We had a discussion with the nephrology colleagues, and they had raised one important, interesting point that they found that the membranous nephropathy incidence is more in persons who eat river fish. An interesting point to ponder upon. I think more research is needed in that aspect also. So the take-home message, the toxin-induced glomerulonephritis is often underdiagnosed and goes significantly underreported. The timely removal of offending agent leads to a favorable outcome. The membranous nephropathy and mid-chain disease stands out the most prevalent glomerular disease observed. Heavy metals, asbestos, hydrocarbons, and a plethora of air pollutants. The list appears interminable. Uncertainties persist regarding the optimal treatment approach. So the need of the hour, the consider proactively assessing mercury levels in nephrotic syndrome cases where no apparent cause is evident. Establishing a registry for toxin-induced glomerular disease is essential in our population. We don't have data. Our nephrology society must actively engage with stakeholders like pharmacovigilance bodies and Ayush Ministry, with Ayush Ministry going around with so much support to the Unani system and the Siddha medication system. I don't know how far is it possible. As we, the South Indians, we are facing the highest burden of toxin-associated glomerular disease. It is imperative that we take a leadership role in formulating a comprehensive management guidelines. So I just want to share our experience with this. So after we broke out the news to media, there was a big hype. The social media hype was there. The drug control was involved. The local police came in. The central agency came. The enforcement directorate came. The CBI came. I have to go to their office first to give the statement. So actually they were linking the creams were actually manufactured in China and Pakistan, and it comes through Dubai to India. So they were checking that angle actually. So 8 months over now, everything is dusted. Everybody have forgotten about it. So yesterday I was just searching in Amazon. So all the creams are still there. It's widely available. So the risk is still there. We have to be more cautious. The public need to be more educated. The risk is still lingering there, and it's very difficult to abolish this from our mentality. The whitening, the fairness mentality is deep rooted in our mind. It's very difficult to abolish it. Thank you. Thank you for the patient listening.
Thank you. Thank you, Dr. Sajeesh. Actually, here also in Hyderabad, and many of my patients and the family, they tend to use those creams, and it was like many of the patients, we have to counsel them regarding this. And definitely it has helped after stopping the creams and all. These are all rampant here. You have mentioned these names. Here, there are no names. They just come without any name. So, like I know about this in Hyderabad community also, there is a lot of things, especially for girls undergoing marriages and all. This is rampant here. I just wanted to ask you, you suggested air pollution nephropathy. Can you emphasize on that, like what is the specific air pollution gases which are involved, or if there is, how to go about it, or any restrictions?
It is a very gray area, ma'am. The data is very lacking. The data, very few data, limited data we have from China. So they have mainly looked into the particulate matter 2.5 and less than 10 micrometer molecules that may be inducing some form of autoimmunity process in this.
Yeah, because in India also, I think the heavily polluted is in Delhi. Subsequently, major cities are heavily polluted.
I think next time we see a patient, we have to think in that angle also.
Yeah, that angle
metros.
Also, and some research is required, I think, in that particular direction. Thank you so much.
Thank you.